An arterial line is commonly indicated for continuous blood pressure monitoring and for patients who require frequent arterial blood sampling. Whenever possible, the use of ultrasound guidance is recommended, as it improves success rates and decreases the risk of complications. Achieving first-pass success is essential, since repeated attempts may lead to vasospasm or hematoma formation, which in turn reduce the likelihood of successful cannulation. There are three main options for cannulation. A standard 20-gauge cannula, which is readily available and effective. A cannula with a built-in guide wire, which increases the chances of success. A Seldinger set with a separate guide wire, which further improves outcomes. Strict infection control precautions are required, including the use of sterile gloves, a sterile field, sterile ultrasound cover, and sterile gel. Procedure: out-of-plane method. After identifying the radial artery adjacent to the radius, the site is infiltrated with local anesthetic into the epidermal and subdermal layers. The bleb of anesthetic is then gently massaged into the soft tissue, and any excess gel is wiped away. A finding needle is advanced using the out-of-plane approach with the hide and seek technique to visualize the needle tip as it approaches and punctures the anterior wall of the artery. Once arterial flashback is seen, the needle is no longer advanced. A guide wire is passed through the needle into the arterial lumen. The needle is withdrawn while maintaining control of the distal end of the wire. A catheter is then threaded over the wire into the artery, after which the wire is removed. Procedure: in-plane method. With ultrasound, the finding needle can be seen entering from the left side of the screen, advancing toward the radial artery. The needle tip is visualized within the lumen, and flashback confirms placement. The guide wire is inserted under direct vision, the needle is removed, and the catheter is advanced over the wire into the artery. Confirmation and post-procedure care. Once the catheter is secured, it is connected to a pressure transduction system to confirm placement. Ideally, the pressure setup should be prepared beforehand or simultaneously with line insertion. Important steps include ensuring connections are secure, eliminating all air bubbles from the system, inflating the pressure bag to 300 millimeters of mercury, positioning the transducer at the level of the heart about 5 centimeters below the sternum in a supine patient. The transducer is then connected to the monitor, zeroed, and the arterial waveform is confirmed. At this stage, the line is ready for clinical use, and post-procedure monitoring should begin.